one at the moment. Let's see. Okay, you may get a flash up saying the webinar is being recorded. Please press continue if you're on a panel and you get that message. Okay, a couple more people coming in. Okay, we're going to go ahead. Now, welcome to this Antibiotics in Society's online panel series. This is number 2 in our panel series. And today we're talking about antibiotics beyond health facilities, pharmaceuticals and markets. The panel series is intending to bring together key insights from the enormous range of social research studies that have increased in number over the last few years. And we had a panel last month which was focused on healthcare and health facilities and the roles of antibiotics there. And today we're talking about pharmaceuticals and markets, so outside of health facility settings. Our intention with these panels is to focus on one particular aspect of the research that people have been doing around antibiotic use. And really, item C here is what we're trying to get to, is what are the implications of these studies for the ways that we address antibiotic use? And that might be in policy, in programs, or perhaps in pilots for research studies. And I'm going to hand over to our chair today. We're really, really fortunate to have Helen Lambert, who previously was brought this whole community together in the ESRC AMR champion role. And we're really, really delighted that she's agreed to chair today's webinar. Over to you, Helen.
Thank you very much, Claire. I'm delighted to be here, and welcome to our participants. We've currently got 58 of you online, which is fantastic, and the numbers may well grow. They're growing all the time, 59. We have a wonderful group of speakers. I'm privileged to know a couple of them, but not all. So without more ado, I'm going to, I won't hand over, sorry, I've got one more slide to offer you, but we've got, I will say a little bit more about each speaker as they come on. As Claire's already mentioned, we're recording the event, so you can also view it on the website later on. This is a webinar, so please use the Q&A function if you want to ask questions. And we're particularly keen, obviously, although you're very welcome to ask questions of individual presenters on content issues, we're particularly keen to try to push forward, as Claire has said, on thinking about what the implications of the social science research we've been listening to and related research has for policy, programme and practice issues. So if you have more general points to raise that may contribute to our roundtable, that would be fantastic. And then if you're having any technical issues, please just use the chat function and put a little A to Rachel Ford, who is online and doing a heroic job of coordinating all of us virtually. So here's the running order. We're going to start off with Papreen Nahar from the University of Essex, talking about marketing of antibiotics and med reps in Bangladesh, which is a well-known phenomenon, at least across South Asia. And without more ado, I'll hand over to you, Papreen.
Thank you, Helen. I will just share my screen. Thanks. As you can see, the title of my presentation is Antibiotic Marketing and Informality, Medical Representatives in Bangladesh. This presentation is based on an ethnographic study which explore the role of specific actor in popularizing antibiotics in Bangladesh. They are called medical representatives and are employed by different pharmaceutical companies. Oops. This study was conducted as part of a larger project, which was investigating the pathways of use and dispensing of antibiotics among people and animals in Bangladesh. This was an ESRC funded, project, and 3 different universities from UK were involved, including Durham University, University of Bristol, and Loughborough be the lead institute. Also 2 institutes in Bangladesh, Brack University and ICDDRB. Medical pluralism is a dominant feature in Bangladesh, and 70% of healthcare service is provided by informal sector. There are more than 200,000 shops, be they registered and unregistered, sell medicines. Antibiotics for both human and animal are available over the counter. There have not been any national studies done to identify the extent of AMR problem in Bangladesh. However, a number of small-scale studies shows that antibiotic is one of the highly prescribed drugs and most prescribed by the unqualified providers. We have used the theory of social lives of medicines in order to investigate the pathways of dispensing antibiotics. White et al. Van der Geest promoted the notion that medicine needs to be understood via its biography. And we have taken a number of steps from production to distribution to marketing to prescription to consumption in order to understand the biography of antibiotic in the context of Bangladesh. The broader study included 4 types of health providers, in qualified, unqualified, auxiliary, and semi-qualified. But this particular paper is based on additional 13 key informant interviews with medical representatives and different stakeholders involved in pharmaceutical industries. Also, we have done non-participant observation to conduct this component of the research. Due to a radical drug policy in Bangladesh in the early 80s, the growth of multinational pharmaceutical companies sector was drastically reduced, and national companies flourished a lot. As a result, over the past 50 years, the number of local companies has increased from 30 to 269. The industry provides second highest revenue to the state, and 90% of the medicine need of the country is met by the local companies. They also export to 72 countries. As part of the radical drug policy, commercial advertisement of medicines was banned in Bangladesh. Within this context, the private pharmaceutical companies have taken an aggressive strategy and emphasize on a specific special workforce known as medical representative, whose main job is to generate prescriptions. In order to achieve that, the companies create prescription potential index, set up target and align territory for each medical representatives. A doctor on an average usual day, they visit at least 20 MR. That creates a challenging competition between the MR on who can win over a certain provider. The sales the sale depend on the quality of the performance of MR. They follow different strategies and get training on managing particularly focusing on behavior, rapport building, relationship, appearance, and using specific time for a specific type of providers. Also, they keep it in their mind that it's a pluralistic system, and they take their approach accordingly. Incentive is one of the major thing for them, and they decide which kind of incentive will be given to what kind of provider, starting from a plastic made pen to a car or apartment. Within the very busy schedule of the doctors or any provider, the MRs get maximum 2 to 5 minutes to talk to them. They call this magical 2 minutes. Since their performance is being evaluated, they also monitor if the doctor are actually prescribing their company's antibiotic after they convinced about it. And therefore, they take a number of measures as well, including taking a snapshot of the prescription when the patient come out from the consultation room. Although MR target all types of healthcare providers for prescription generation, their main target are specialists and MBBS doctors. And this is because convincing more qualified big doctors has a number of trickle-down effects, since their prescriptions will be followed by junior doctors as well as the semi and unqualified doctors. Their other target is generating prescription of antibiotic. This is because a big doctor prescribed a certain antibiotic. It signals to the others that the doctor has gained confidence on that particular company. This results in increase the sales of not only of that antibiotic, but also the other medicines of the company. And also there are bonus remuneration allocated for MR in relation to the sales of antibiotics. There is no state level policy or regulation on MR, despite the fact that MRs play a vital role in promoting antibiotics in Bangladesh. They are completely absent in the formal health system, health workforce, and health policy discussions. They function completely informally. The marketing of antibiotic take a special form in Bangladesh through a particular agent called MR, as I introduced them. MR follow a well thought out, robust, and complex mechanism to popularize antibiotics. MRs function in Bangladesh in an informal healthcare system, which is in the context of an informal and deregulated healthcare system. Informality, a double-edged sword. In one hand, regulating in the informal sector is necessity, full stop. But on the other hand, regulating informality may generate inequality. As you know that Bangladesh has achieved most of the Millennium Development Goal 4 and 5, and also UN has recognized Bangladesh as an example of good health at low cost. All of these are made possible by engaging the informal sector. We argue that uncritical transfer of universal model of mitigating AMR is therefore problematic. We acknowledge critical understanding of informality is in the healthcare sector in developing countries is important. The health system, a formal one, is considered to be contingent on Western experience and Western epistemological framework. It has been observed that inadequate attention has been paid to the non-Western ways of health service management characterized by informality. Based on observation in India, Anunna Rai suggested informality is not a failure of planning or absence of state. Rather, informality is a system of deregulation, which can be thought of as a mode of regulation. In such a context, deregulation is a calculated informality. So, in order to formulate a contextual AMR mitigation policy in developing countries, understanding informality in the health sector is critical. The big question remains, how do we understand that, and how do we set up the roles, and how do we define informality within the context of Bangladesh or in developing countries? Thank you.
Thank you very much indeed, Papreen. I think we should have a round of virtual applause for all our speakers. Wonderful. I'm not going to invite questions now. We're going to move straight on to our next speaker. But we've already got some really interesting, more generalizable points here, which we'll see whether they are picked up in subsequent talks. So I'd like to move on now to invite Marco Haenssgen. I'm never quite sure how to pronounce your surname, Marco, so I'm sorry if I've got it wrong. Perhaps if Papreen can stop sharing her slides, then we can get Marco's first slide up. And by the way, beautifully timed and no need for me to wave or shout at you. So thank you very much for that. Okay, I'm delighted to introduce Marco, who has been doing amazing work also in the region of South and Southeast Asia for some years now. And he's going to talk about antibiotic reuse in relation to health behavior. Over to you, Marco.
Thank you very much, Helen. And also thank you for the organizers for inviting me here on this panel. This is very exciting. In the interest of time, I get right to it. So I've been asked to talk a little bit, about our research experience in Southeast and East Asia, and to bring in a big picture perspective from a range of mixed methods research projects into our understanding of antibiotic markets. So what I'm going to talk about is basically just a summary of a range of projects that look at health behavior and context. What do people do when they're sick? What are the complex processes that they go through? At which point do they then use antibiotics, for instance? What are the different patterns of healthcare access? But also what are the individual and the contextual drivers that shape that behavior? So that will be the focus of this presentation. Translating it into markets for antibiotics, I think a useful way of looking at this is the idea of a healthcare activity space, the interface between patients and health systems, broadly defined. What does it mean? It means that we look at the market, not just in terms of supply and demand, but actually as a physical and social environment in which people behave. So who are these people? On the one hand, it's patients, right? So conventionally the demand, but patients exhibit very complicated and complex healthcare behaviors that are often subject to contextual forces, to the environment, the immediate environment, but also historically grown, politically shaped circumstances. And that's on the one hand. Now patients then navigate complex, obscure health systems, just like Papreen just outlined. There's a lot of informality. It's not just public doctors and private clinics, but it's also faith healers. It's also ex-military doctors dispensing antibiotics. It's also households storing and sharing antibiotics with each other. There's a lot of informality, quite naturally, but also it's a system, again, populated by people with their own struggles, with their own ideas of how to produce health, whatever health locally means. And then what connects these two? What connects these two is a network of solutions, we could call it, things that enable this navigation of these complex healthcare spaces, in which then people use mobile phones, cars, roads, whatever is at their disposal, also information, in order to realize this treatment-seeking behavior. But it also means that external interventions come in there and then interact and interoperate with this existing network of solutions, synergistically, but potentially also detrimentally. So all of this together is, for me, a market. And the market, the activity space, is then also subject to external influences, global health policy, national health interventions. So what I'm going to do in the next 10 minutes or so is translate some of our key findings from this range of projects over the last 8 years across Asia into this idea of a healthcare activity space as markets for antibiotics. Now, starting with patients. Well, it's not a surprise to anyone probably here in the audience that behaviors are really complex, complicated, often syncretic, combining different healing philosophies, even within the same process of seeking care. So I'm not going to elaborate on this any further. We take it for granted. We should take it for granted at this stage anyway. But let me talk a little bit about economic environments, economic circumstances of individuals and households. Well, one basic thing that we quite often see in a range of countries is that as households, especially in rural areas, become more affluent, become wealthier, they change their treatment-seeking behavior. It shifts often from public healthcare to private healthcare seeking, and then also associated patterns of antibiotic access, which means that different degrees of regulation apply as people become more affluent, as households become richer, potentially. Now, we can say that households becoming richer might be a good indicator of economic development, but economic development, whatever that means, is not necessarily always positive. Economic change means that also economic organization and people's environment changes. So also we see in our study areas a lot of prevalence of precarious livelihoods. And in a recent study that's about to be published, we documented, for instance, that when people have or live in precarious circumstances, when they have little predictability of their economic prospects, when they are deprived of social support or institutionalized safety nets and are being forced into what we could call a toxic form of self-dependence, then they're actually more likely to overuse antibiotics in detrimental ways, in a way that doesn't correspond to their clinical presentation. What it means is that in precarious livelihoods, behavior looks irrational. Antibiotic use looks irrational. People overuse antibiotics as a quick fix to care, as colleagues, for instance, from the London School, for instance, Claire Chandler, have pointed out repeatedly in the past. So we have empirical evidence documenting exactly that. Now, what's the consequence of that? The consequence is that context shapes a lot of this treatment-seeking behavior. Adverse contexts shape a lot of adverse treatment-seeking behaviors. It means that we cannot educate it away, or we cannot wish it away through individualized interventions. Individualized interventions that are often the center stage, the key parts, the backbone of global health interventions in antimicrobial resistance. For instance, educational and awareness campaigns. But even then, even campaigns that focus on the individual and individual knowledge deficits, which they not only are they a very small facet of behavior sciences knows that, but also we documented extensively in our work that this link between education, knowledge, and behavior has many broken links. There's nothing straightforward in making this assumption that knowing more automatically improves behavior. It doesn't happen like this. As a matter of fact, we even documented that more formally educated people have worse health behavior because they're more assertive about their own health, because they think they know what's best for them. So you cannot automatically assume that education improves behavior. That's one thing. That's the patient side. Now, what on the health provider side or on the health system side, broadly speaking? As Papreen said, there's a lot of informality out there, right? And that our study areas are no exception. So let's not embark on this a little. Let's not embark on the informality of it further. Papreen has given us a fascinating presentation. But let's look at the formal sector then. Let's look at what, say, private and public doctors do. Public doctors in particular, or public doctors and nurses. Well, we see that often in global health policies, there's an assumption that antibiotics are being overprescribed to patients because healthcare providers, former healthcare providers, annoyingly just give in to this demands from patients and therefore just give them too many antibiotics. It doesn't happen like this, at least not in the way that we see it. We've seen a lot that healthcare providers have their own tactics and rationale for overprescribing antibiotics. They do that. They know it's not necessarily the best thing. They are aware of drug resistance, but they feel compelled to do it. Why? For instance, because the epidemiological environment compels them to err on the side of caution, because they don't want to bear responsibility for patient death who could contract a deadly infectious disease in their environment. The doctor doesn't want to bear the responsibility for that, so therefore prescribes an antibiotic just in case, knowing it's not ideal, but it's the best of two options here. Similarly, nurses choosing the lesser of two evils, prescribing antibiotics to patients when they demand them, because if they don't do that, they know the patient will go to a corner shop, buy antibiotics over the counter, and then take them unsupervised. So at least now we have supervised antibiotic use, even though we know it contributes to AMR, but it's the lesser of two evils. What it means is that antibiotic prescription is embedded in ethical dilemmas, in social realities that are always there, and they constitute context that shapes prescription behavior. What does it mean for policy? It means that when we have regulatory interventions, for instance, that try to force healthcare providers into more regulated prescription behaviors and more stringent monitoring and maybe even financial sanctions or at the threat of firing them from their job, that can create real problems. Why? Because the policy realities don't match the local social realities of prescription. What are the consequences of that? Well, the consequence of that are, on the one hand, you silence all these dilemmas that are there anyway, but you just now pretend they don't exist. They're still there. They're still dilemmas. That's on the one hand, a problem from a social perspective. But also, on the other hand, it creates subtle forms of resistance in which the healthcare workers start falsifying data because they cannot make these realities match. It's not because they want to falsify data. It's not they're so desperate to prescribe antibiotics, but they can't match these realities. And then it looks like policy is working because the data look nice, but actually we are just fooling ourselves because we're not responding to the context of prescription behavior. So that's on the health system side. And then what connects these two? A network of solutions into which then external interventions are being introduced. For instance, awareness campaigns, often not sensitive to local contexts. meaning that they don't correspond to local notions of illness, to local notions of antibiotics, to local treatment-seeking behavior, and then can cause more confusion than clarity, and upset behaviors produce unintended negative consequences. Even diagnostic biomarker tests, which seem so objective and so disembodied when they're being transplanted to a new context, they are being reinterpreted like any technology into a new context. And they can provoke new interpretations of what the test does. In a similar way as we have learned with colleagues, for instance, from the London School of Tropical Medicine in Sub-Saharan Africa for rapid diagnostic testing for malaria. Here we have a new test that reconfigures this relationship between patients and healthcare providers, meaning that it can accidentally upgrade, so to speak, healthcare provision and create demand for formal healthcare. That's a good thing, a positive unintended consequence. But it can also lead to patients behaving more riskily because now they think they got a comprehensive blood test and everything is okay with them. And then produce risky health behavior, potentially produce deaths in the worst of all cases. But even if we don't intervene, the context is always there. We have to appreciate the context, and the context changes. One of the very rapid forms of contextual change that we've witnessed is mobile phone diffusion. Now, as mobile phones diffuse, they work like increased wealth. They break down barriers of marginalization and they create greater inclusion on average into the formal healthcare system, which also means that therefore more antibiotic use is now falling into terrain that we can regulate. That's a good thing. On the other thing, mobile phones enable quick fix solutions of antibiotics when people experience precarious livelihoods. So
Marco,
we have a
two-sided.
two-sided.
To the end of Marco, could you start to wrap up now because you've only got about less than a minute left?
Certainly. So the technological change, the contextual change can then also create problematic environments and problematic patterns of antibiotic use that then look irrational, but really are driven by context. And so we have to understand this context. That's the bottom line here. And for that to be possible, we need to give bigger voices to low and middle-income country civil society, but also researchers. I shouldn't be here speaking about Southeast Asia. It should be someone from Southeast Asia, right? So my right of existence on this panel should be undermined by great inclusion of representatives, and not just academics from low and middle-income country, enlightening us about context, how context matters, what are local priorities, because maybe also foregrounding antibiotics is not a local priority. Maybe antibiotic misuse or overuse, whatever it is a symptom of broader, deeper-rooted development problems, of which antibiotics are not one specific example, just one example. And we have to find that out. We also have to understand local context for context-sensitive interventions. Very simple qualitative and participatory research itself can already go a long way in helping us understand where should we intervene with diagnostic biomarker tests, how can we integrate them into existing behaviors on the ground. Overall, I call for more intersectorial work in which we take out biomedicine, Western biomedicine, out of the focus and put it side by side local representatives from low and middle-income countries, but also broader development organizations, World Bank, International Labour Organization, United Nations Development Programme, Food and Agriculture Organization, OIE, environmental organizations, because they all comprise context so that health policy itself becomes more intersectorial. Thank you for bearing with me, and I hope I still made it within 12 minutes. Thank you so much.
Thank you very much, Marco, and thanks for wrapping up quickly at the end there. We're going to move right on now to our third panelist, Susan Nayiga, who I think is coming to us from Kenya?
Uganda.
Uganda. Great. And I think it would be great if it's possible, Susan, for you to try putting on your webcam, if your bandwidth will allow.
I'll just turn it on for a short while to introduce myself. Just to say, from the Antimicrobials in Society project in Uganda, and I'm going to be sharing findings, insights from our work, trying to understand the roles and context of antimicrobials in rural, urban, and peri-urban settings in Uganda with a focus on humans and animals. Please let me turn off the video just so the internet can sustain me through this. So briefly, I would like to point out that relatively little is known about community level antibiotic use in low and middle income countries. and yet without detailed information on antibiotic use, interventions to optimize antibiotic use will be limited to a generic design, which has hampered their effectiveness in the past. So to better understand patterns of antibiotic use in Uganda, we started our project by conducting cross-sectional surveys in 3 geographic locations, focusing on households and piggery and poultry farms. Between May and December 2018, we conveniently selected and enrolled households in Nagongera, which is our rural site, households in Namuongo, which is an informal settlement in our urban site, and poultry and piggery farms in Wakiso, which is our peri-urban site. Using the drag back method, we engaged participants in an exercise to identify antibiotics they frequently used, but also to tell us about the sources of these medicines. So just to draw your attention to our paper comparing findings on antibiotic use across these 3 geographic locations. This was published last week in the Journal of Antimicrobial Resistance. I'll now highlight some of the key findings presented in that paper from the medicine surveys. We found that the frequency of antibiotic use varies from place to place, as does the types of antibiotics being used in different areas, particularly between the rural and the urban areas. We also learned that the majority of antibiotics frequently used for human treatment belong to the access category of the World Health Organization's AWARE classification. For animal treatment, we learned that most of them belong to the highly important category of the critically important antimicrobials classification. We learned that most of the antibiotics were acquired from the private sector for both human and animal treatment. And to give this some context, I would like to point out that the healthcare in the public sector in Uganda is free of charge. The veterinary sector, on the other hand, is predominantly private. The government does employ animal health workers, but may need to provide advisory services to farmers and preventive services such as vaccination. So these same animal health workers will operate as private animal health workers when they offer treatment services. Another thing to note is the private sector in Uganda is quite formalized. For instance, drug shops are licensed and regulated, although you still, in reality, in everyday life, find that the drug shops operate beyond what is allowed for them legally when they sell antibiotics, and yet they are supposed to be restricted to selling Class C drugs, which are over-the-counter drugs that do not require a prescription. I'll now talk about some of our findings from the ethnographic fieldwork. We've come to learn about the current everyday realities within which antibiotics are used across the 3 settings. And I'll give 3 examples from the 3 sites of what we've learned. In our urban study site, which is an informal settlement, people experience frequent flooding, which draws human fecal material and all sorts of stuff into their houses. They have limited access to toilets and grapple with water contamination, predisposing them to high rates of infection and disease. In this setting, we've learned that antibiotics are a convenient and practical way to cope with frequent episodes of diarrhea, well knowing that they have limited political power and are unable to demand for change. And of course, they have limited access to good health care. In the rural study site, people are grappling with chronic ill health amid this limited access to good quality health care, as well as clean water. And so residents have resorted to taking antibiotics in a piecemeal way to be able to tolerate the lingering forms of ill health they experience and still continue to do their garden work. So in this setting, we've learned that antibiotics fill the gap for care in a fractured health system, but also sustain productivity through enabling people to continue with their garden work even when they are unwell. Among commercial piggery and poultry farmers in our peri-urban site, we've learned that amid these heavy financial investments, and numerous risks that they shoulder with no safety nets, antibiotics not only provide immediate treatment and prevention of infection, but also protect financial investments and livelihoods. And so, drawing from these findings, I'll now talk about some of the issues for consideration when addressing antibiotic use. Firstly, recognizing that antibiotics are used differently across settings and populations, there's need to move away from one-size-fits-all interventions and tailor interventions to optimize antibiotic use to specific settings and populations. Secondly, targeting structural factors driving antibiotic use across societies is crucial. And I will now share some examples of how this could be done. In the rural and urban site where access to clean water and water contamination is a big problem, investing in a safe water system is likely to be more effective for reducing antibiotic use than simply asking people to reduce their antibiotic usage. When we look at the commercial farmers, providing safety nets such as an insurance scheme, for instance, to avoid them turning to antibiotics for protection of financial investments and livelihoods might be more practical than asking them to refrain from the routine use of antibiotics. Addressing the inadequacies that draw people away from the public health system, despite care being available free of charge, will be more effective than asking people not to buy incomplete doses of medicines, for instance, from drug shops and pharmacies, and yet they can't even afford to buy their next meal. My last example will be that in a country like Uganda, with a shrinking public health system for both humans and animals, and a dominant private sector, improving regulation of the private sector might be more effective than asking people running drug shops, for instance, not to sell antibiotics, or asking animal health workers not to hawk or sell antibiotics in markets like we've observed in our rural site. So the third point I would like to put out is that through our interactions with participants, we have learned that they are keen on learning more about how to use antibiotics to treat themselves, but also their animals. However, we've attempted to follow up with professionals on the possibility of doing this, and this has been met with resistance as they seem to believe this information should be restricted to qualified professionals. And this is a barrier because, as you all know, medicines move outside of the boundaries of professionals. And so there's need to address this issue, probably starting off with having discussions with key stakeholders on how best to handle this. I come to the end of my presentation. I would like to acknowledge the MS Uganda team, the IDRC team in Uganda, our study participants and key stakeholders, as well as our funder. Thank you for listening.
Thank you very much indeed, Susan, for that incredibly clear talk, and actually for finishing before time, which is fantastic. And just to let you know, since we started, we've now got 75 participants here online with us. So although it may feel like we're in a very small room, we're actually across the world. Let's move straight on now to our final presenter, who is Mark Davis, and who is clearly enjoying a beach holiday at the moment.
Thank you very much, Helen. I'm just going to share. Brilliant. Well, thanks so much for inviting me to be here. It's sort of 9 o'clock at night in Melbourne, so a bit different to England, I guess. And I've been asked to talk about my AIC project. That's a big qualitative project about general public, so people outside of clinics, and their perspectives and beliefs and practices around infection and using antibiotics. So the work I'm talking about comes from some of the things I want to talk about at the end of the paper come from a range of projects that we've been funded to do, both by the Australian government, but also working with colleagues in Scotland on some public health oriented research looking at how to inform in the national campaign in Scotland. And Monash University also funded us to look at culturally and linguistically diverse populations in Melbourne, about how they were experiencing AMR and antibiotic use. So there's kind of a range of qualitative work happening here with a range of people both overseas and in Australia, and in a range of disciplines, so clinicians, infectious diseases people, anthropologists and sociologists, and media people actually working together on this project. So the data I want to talk about today comes from the DP17, the Building the Australian Response to the Superbugs Crisis. So this is a qualitative study. We ended up interviewing a large group of people, 99. They really wanted to talk to us. It's one of the key findings is that people actually do want to talk about antibiotics and superbugs. And we're basically framing the work around using perspectives from illness narrative, immunity theory, sociocultural perspectives on immunity, and sociocultural perspectives on pharmaceuticals. And we've looked at really the ways in which people narrate their experiences around antibiotics and AMR in these interviews. It's a relatively diverse group. 35% of the people were born outside of Australia and English wasn't their first language. So there is some diversity, but it additionally fairly well-educated group of participants. And we asked them all sorts of things about their use of antibiotics with themselves, with people they care for, with their pets. We asked them about how they use media, how they find information about AMR, what were the trust factors in relation to the kinds of media they were consuming. We even took the step of showing them a television news item in the interview to get them to talk about superbugs and so on. And notably, significantly, quite a few people were kind of surprised to find out how big an issue AMR was. And it was kind of telling that this kind of well-educated group of people were in 2019, 2020, kind of surprised that there is a crisis. So what we tried to do is understand the different kind of contexts of antibiotic use. So we're in the phase of working with stakeholders about how we could articulate our findings with the current national policy, and finding ways of making some kind of practical recommendations about how to proceed. And I think picking up on some of the things other people have said already, contexts are so important, and we crucially find that antibiotics are not the defining kind of principle of healthcare out there in the world, and that antibiotics use arises in myriad ways in specific contexts, and they have some commonalities but some differences, and being sensitive to those contexts I think is part of the key to better communications and policy work. So there are five that we can find, and I'm sure there are others, but these seem to be the dominant ones for our group: pet care, travel, parenting, and something we're calling early intervention, and something we're calling self-care. So each of these are moments in a person's life course where an infection emerges or a health crisis emerges, either in a child, a pet, or oneself, where the person embarks on a process of trying to deal with that infection. May not involve antibiotics, but antibiotics might turn out to be important. The early intervention is interesting because these are groups of people who have a chronic diagnosis and have a pattern of use where they will seek out antibiotics quite early because they know that if they don't, they become sicker. So these are people with cystic fibrosis, chronic lung disease, diabetes, or other kind of long-term infections, and they have a strategy for managing infections, incident infections, that involves early intervention. Then there are a group of people who will embark on, I think, Marco talked about syncretic kind of healthcare strategies, will kind of deploy a range of approaches. And if those don't work, then they move into seeking a prescription from a medical practitioner. So I just want to give you a little insight into the kind of narratives we generated both for pet care and for parenting, because these are very interesting kind of contexts where the kind of moral imperatives on acting and the kind of issues about trust and expertise and who gets to decide and how risks are managed come to the fore. So here we have Jenna talking about how she manages her, the life of her pet. And she reflects in this way to say that animal health, you know, with human health, you can engage with it a bit more. You can give your opinion because you're experiencing it. You can learn about it. But animal health, it's like the vet knows and you've just got to trust them, you know. There's not really much engagement when you can't ask the animal how they're feeling, and we're all scared of hurting our beautiful pets. So we do as we're told. So this is a kind of keynote narrative, and Jenna lays out for us the kind of moral imperatives around the care and how therefore antibiotics emerge as the kind of strategy there. In another example, which I hope to find, comes from Trevor, reflecting on the management of infections in his children and kind of laying out a different set of issues. And what I'm trying to, you know, the impression we should get here is that Trevor and his partner are trying to manage a kind of distressed child and trying to make decisions to manage the child's illness and kind of, you know, engage with experts, but all the time thinking about their kind of, you know, the underlying strategies around how to manage infections. And he says, when she was born, I was like scrambling to, like medical staff always come and go, you've got to do this, this and this. And as a parent, most of the time, you've just got to go, okay, all right, whatever you say, just give her whatever she needs to do kind of thing. But it's kind of like if I'm being a difficult parent, being overly sort of, you know, hippie and sensitive, saying, my child doesn't need antibiotics. So that's when I have to look it up then, I guess. So Trevor's kind of pointing to some issues around how to, you know, he's aware that there's a superbugs crisis. He knows that antibiotics shouldn't be overused, but the medical practitioners are recommending it. So how, you know, what are the imperatives that come with parenting in that particular context? So this has led us to try and put these contexts into some kind of sociocultural context, a wider context of how people deal with health. And so I guess we're not following the drugs so much, but following the stories about how people think and feel about immunity, infection, and health, and understanding how antibiotics might be one strategy that comes to play. So this kind of diagram tries to navigate this complexity. And I think the thing to hold on to here, so much of the health education we do around antibiotics assumes that general populations are kind of individuals and rational all the time. The impression we have is that in these contexts, people are managing situations that aren't completely under their control. So they are risk managing emergent threats, minor ones through to major ones sometimes. There's also what unifies these strategies is different engagements with body time. So we've got the early interveners versus the self-care people who might try a range of things, and how that plays to antibiotics time, How long do they take to work? How long should you take them? When should you finish them? And there are interesting kind of nuances here in trust. So it's not just trust in the kind of prescriber or the dispenser, but a kind of notion of body trust. I trust my body to get well, or I trust that I know my body will get very sick if I don't do something quickly. And there's a kind of shades of accepting expert advice in a skeptical way, or even in a kind of pragmatic compliance, knowing that there's an issue about overuse of antibiotics, but bracketing that aside in particular contexts. So we're trying to understand those contexts to kind of formulate some kind of recommendations. And these are draft, and we're putting this to our stakeholders and getting them to debate with us about what these about these kind of recommendations. And we've done them for a whole sequence of issues that we think are pertinent, so around media use and so on. But just to give you a flavour of the kind of things we're trying to do is to kind of pull together a kind of menu of messaging and how to articulate sensible messages about antibiotic use with what we're learning about its contexts. So you'll see that in number 6, we're suggesting that interventions around antibiotic use in general populations have to resonate with the context of at least pet care, travel, parenting, early intervention, and the self-care. We also think that patients, members of the general public who present and don't get a prescription, they need to have that explained to them pretty well. So it's not just antibiotic use that needs to be explained, but the strategies that the individual should partake of in those circumstances when antibiotics aren't necessary or justified or required. So there's a kind of, the messaging needs to get beyond antibiotics in a kind of limited sense. So that's actually the end of my talk. So thank you very much. And I'm hoping we can talk more about those kind of recommendations as we progress in our roundtable. And my images here aren't really a joke. I think that we need to look at the historical context, and that publics have been given a range of messages about what antibiotics can do over the 20th century. And so, asking them to shift their practices in the face of the kind of weight of history that's coming behind them is something we really need to think through. So thank you very much.
Round of virtual applause from Mark. Thank you very much indeed for that really clear and well-paced presentation. We've actually stuck to time beautifully. So we do have time now to have a bit of a discussion, as well as to pick up on some of the questions in the Q&A. We're getting a lot of really interesting questions coming in. We may not have time to address all of them in the session itself, but the presenters may be able to answer some of your questions live if they're on a particular topic. What I suggest we do first is we have a bit of a roundtable discussion, just trying to pick up on some of the key issues that were raised in more than one of the presentations. And I think I can see there are some clear strands emerging. And Claire has suggested that we do that first and then move on to the Q&A after that. So I've been scribbling frantically, trying to pick up some of your really rich and interesting presentations. But I guess a couple of key things that I see have emerged in several of the presentations, of course, is the issue about regulation and regulation in relation to informality. So Papreen talked about Bangladesh having this, what she describes as in effect, a deregulated healthcare system and a huge amount of informality, so a very vibrant informal sector, which of course these medical representatives, i.e. the market end of things, are influencing strongly, and argued that regulation in the informal sector is necessary, but may increase inequality. And then we've had, again, sort of touched on less directly in Marco's presentation, but he spoke to the fact that when we have regulatory interventions that try to enforce limits, of course, then the realities mean that people simply try to get around those limits, such as the way in which prescribers will not report their data on prescription accurately. And so I think this is, it's an important issue. And I think, and Susan also mentions apropos the provision of antibiotics that, you know, providing regulation of the private sector is crucial. So everybody has talked about the way in which different contexts are incredibly important, which they are. And I think that's something that social scientists have been saying repeatedly for a long time without perhaps getting much traction. But I wondered whether any of our panelists would like to pick up and speak to this point about regulation, in particular, as it concerns the private sector and that interface between public and private, and what your findings might be suggesting in how we grapple with this complex question. Does anyone want to speak or say anything further about that?
Shall I?
Yeah.
So antibiotic use in Australia is all pharmaceutical benefit scheme, highly regulated. But what we know is that people don't finish their prescriptions and keep them, their prescriptions or their antibiotics, and traveling, obtaining them overseas in various ways, and transnationals, across different kind of cultures of health and antibiotics. So bringing antibiotic with them in either direction. And also increasingly, we're looking at the online pharmacy. So that is now, it's in Australia as elsewhere, it's possible to buy antibiotics for yourself, from everything from yourself to your fish farm, to your farm, online, off prescription. And I'm not sure that our governments are quite up to speed on the implications of that for managing antibiotics. So that's kind of, I think, one frontier that we need to start looking at here in Australia.
Yeah, it's clearly possibly a too difficult question to just throw at you and ask you to speak about off the top of your head, but I think it's clearly an area in which and it's something which it's something that I have been working on a bit in a small seed project on regulation and resisting regulation. And I think it's something that potentially a lot of our empirical social science work can speak to in an important way. But it's quite a subtle relationship between what we actually find what we find occurring and what implications that would have for how we regulate, or even how we conceive regulation to be, because we've got an inherent tension here between everybody recognizing that there is a need for some sort of regulation or management of what goes on in terms of antibiotic provision, over-the-counter purchasing and so forth, and a recognition among social scientists that that really the ways in which regulation is performed are ineffective because they rely on the metrics which are produced by the people who are being regulated. A second area that I thought was sort of there as a strand throughout most of the presentations in one way or another, of course, relates back to the previous panel and to Claire and the AMIS group's work on antibiotics as quick fixes and you know, filling the gap. And Susan spoke very clearly to this about the way in which they substitute for care in a fractured health system or in environments where we don't find pre-existing, you know, good health provision, clean water, sanitation, and so forth. I guess my question to the panel again would be trying to push you a bit further on this. We keep saying this as social scientists, you know, that they're kind of, you know, antibiotics perform care and that they act as a quick fix. But on the one, there is a sort of potential tension here in his, because by saying that they do this, and this is why people are driven, as it were, to just buy an antibiotic and use it. We're saying this in relation to a situation in which we're also arguing that antimicrobial resistance is a major problem. So if the antibiotics don't work, what are we saying people are doing? And I think this links, as well as Mark's final point, and Papreen's as well, it links back to the discussion in the last panel about why antibiotics are still seen as a wonder drug, and what are the cultural or other or societal assumptions that lead people to continue to resort to antibiotics as a quick fix. So we can demonstrate rationality, but how does that help if the rationality still is relying on a sort of biomedically produced assumption that, you know, antibiotics are the solution, when increasingly they're not the solution? So I just wondered, and I have some ideas about this myself in my head, but I wondered whether I wanted to speak to that question, and perhaps also to Mark's comment at the end that we need to understand these things historically. Marco, and then Papreen.
Thank you, Helen. I think you raised a really good point here. On reflection, and I'm speaking my mind here, I haven't got a very well formulated response, but in reflection, I would say that you're absolutely right that antibiotics not working then creates quite a paradoxical situation. But is it actually about antibiotics working, or is it more about a claim to agency in situations of despair, and that antibiotics represent an assertion of agency? And maybe antibiotics are then not unique in the way they do it. Just because we foreground antibiotics doesn't mean that they're the only way in which we do that. Painkillers are quite usually used quite widely, only we don't see it as a global health problem because the complications might then be more localized on the individual, and it's not foregrounded in policy. Again, it's still within the biomedical domain, so that doesn't solve the other dilemma that you raise. But then there are also other technical fixes that have been propagated that help sort of absolve responsibility, help resolve ethical dilemmas in a way that we can assert our control or comfort over our own environment, for instance, through new risk bands to allocate resources in refugee camps, for instance, through diagnostic biomarker tests. So here, the objects themselves acquire agency and acquire an active role in this interaction, in these problematic, contextually shaped situations, of which antibiotics are perhaps only just one example among many others.
Yeah, thank you, Marco. Papreen?
Thanks, Helen. A really interesting issue that you have raised. I mean, rightly you have said that antibiotic has been considered as a medicine of power. That's what we learned from our study. And also they consider it as, it has got a nutrition value in it. And even, I mean, it's a preventative medicines. So this kind of ideas are there within the communities in Bangladesh, and particularly with the unqualified drug sellers or dispensers. And this is happened because of medicalization process. And we now I mean, it's people have changed their perception about health-seeking behavior. And also, I mean, it's not only traditional medicines when we explain medical pluralism in traditional anthropology, we used to say biomedicine and alternative medicines or traditional medicines. But now we know that within biomedicine, there are so many varieties of health provisions. And through that process, actually, people, I mean, indigenous belief these days are very much contaminated with the, I would say, contaminated with the biomedical science. And therefore, I mean, it's very hard to change people's behavior, and also even it comes to the issue of people's perception. It's probably, I mean, almost near to impossible. But it doesn't mean that there is no way out for us. And I think, I mean, it's there is no alternative, but we need to do more research on people's local practice prior to use antibiotics, and bring their ideas, and then talk about those ideas again, and introduce those local beliefs, what kind of practice they used to do before introduction of antibiotics, and also before introduction of biomedicines. And yeah, that's one thing. And also, like I said at the end of my presentation, that in order to formulate a contextualized AMR mitigation policy, understanding informality in health sector is crucial. We need to understand the informal ways that they are distributing health services. And then if we understand the informality and also understand the local indigenous practices and their ideas, and then in combination of these two, we can come up with some ideas to prevent this overuse of antibiotic, probably. And of course, with the regulation, proper regulations. And I mean, in terms of regulation, I don't entirely believe that strict having a rule or regulation means that people are going to change their behavior. So there are, I mean, it's, as an anthropologist, like you said, that we need to understand what people think about it and what people want to do about it, and then go with that. Thank you.
Thank you very much, Papreen. I guess it's interesting to hear you advocating that we should go back to kind of looking at local people's understandings and beliefs, because I think one of the things that your presentation brought out clearly was the role of the pharmaceutical industry. And we have talked indirectly about markets and so forth. But it is something that has not been prominent in terms of policy making very explicitly. I mean, this does loop back a little bit to the issue about markets and regulation, but it might be worth just thinking about you know, why this has not been visible in very much in social science work, and why the pharmaceutical industry has not, and its employees, I suppose, including med reps, has not been considered a prominent actor, and whether this is something that we perhaps need to shift our focus to slightly. And then I've got one follow-up question for you from that. But yes, does anyone want to?
Yeah.
Yes.
Can I just add?
Yes, please.
No.
Yes, go ahead.
Susan also was trying to say something, just so you know.
Oh, I'm sorry, I missed.
She doesn't have a video.
The Papreen and then Susan.
Okay.
Okay, thank you. And I think, I mean, it's the discussion of medical representative is not in the table because of its in informal sector again. And within when we have been doing the social lives of antibiotics in the context of Bangladesh, we found that the medicines, the antibiotics, the they're born in the same place, in these same industries. But then the next step of distribution and marketing and prescriptions takes two different ways for government and for informal sector. From the government sector, we came to know that after the production, the distribution is distribution of medicines or antibiotics takes a specific pathways. It goes through the Directorate General of Drug Administrator through the Health Ministry territory. And also there are some assigned essential drugs listed for the government sectors. So that is regulated. And when it comes to the issue of policy, then only we talk about the formal sector and regulations and actions. But because after born these antibiotics, in the informal sector, they do not go to the, the distribution process, follow the marketing side, which in the government sector, they don't have to do the marketing. From the distribution, they go to the prescription and then consumption. So there are difference between these two.
Yes, so that again is speaking to the issue about this public-private dimensions, which several of the panelists have spoken to. Susan, would you like to come in on that point?
It's actually, I have a contribution on another point regarding alternatives.
Okay.
Yes, from the discussions we've had with some of our participants regarding what else can be used other than antibiotics for infections, they've pointed out clearly that for animal treatment, it's possible to go back to what used to be the case in the past, where there was a lot of use of herbal medicine. But then for humans, they've sort of repeatedly said that with humans without antibiotics, they will die. They will die. And their idea is that with modernity, we now have new diseases, what they refer to as new in quotes, things like cancers and all sorts of diseases coming in, which require strong medicines, again in quotes. And so they perceive antibiotics as something strong, and herbs probably not strong enough for a new or disease of the modern times. And also I've been spending time in health facilities where I've been having the same conversations with health workers in lower level health facilities who have also expressed that it might be impossible to reduce antibiotic use, but maybe try to address polypharmacy, especially in a setting where the people are sort of chronically ill and present with multiple infections. So they are treating also in anticipation of what's happening within people's households and all that. That's my contribution.
Thank you, Susan. Yeah, absolutely. I think this probably links to a final sort of thread that I just wanted to invite you to reflect on, and then also to raise a point shared by Claire with me on the chat. It's partly sparked, my thinking was partly sparked by a sort of slightly kind of not offhand, but a remark that you made, Susan, at the end of your, I think it was the end of your presentation, to do with, but I know it's an issue that's familiar to all of us, which is, and again, linking back to the public and private, is that there is an issue about information flows, and this picks up on what you've just been saying about what people think antibiotics are for and what they do, and whether it's appropriate to use alternative or traditional modes of treatment rather than antibiotics. And what we see, of course, is that what happens in the healthcare sector and in the government sector or the private sector and outside it are inherently linked, and they determine each other. So, what people think about antibiotics is not some perception, cultural perception that sits out there. It's something that arises from the interactions that they've had historically over years with healthcare professionals, and what maybe the doctors have been pushing on them because they're being incentivized by the industry and so forth. So I think it may be one of the possible insights we can draw that from these social science forms of research, that we need to develop policies and interventions that consider those information flows across the sectors. And if we think about policy and, you know, WHO action plan, for example, they're chunked into different aspects, aren't they? You know, so, you know, we need training of healthcare professionals, and we need a policy for, you know, environmental transmission, and these separate policies. I wonder whether if we want to think about this more broadly, whether each of the panel has a thought on how we might try to, as it were, bridge those very divided approaches in policy, which I think all your research speaks across to some extent. I just wondered whether there are, you know, or whether indeed there are any more, you know, any, if you'd like to volunteer sort of one single suggestion about how that might be done. And I think that connects with Claire's invitation to maybe speak to these broader underlying development issues, because what we're always doing is saying, oh, we need to connect all this back up. Maybe I could just go around the panel, and then I think I'm going to move to some questions that have been coming through on the chat. So I'll just start going round from who I can see on my screen in turn. Marco, I'm sorry if I'm being very vague, and
you're putting me on the spot here. I don't think I have a ready answer from the top of my head, I'm afraid. But what I think is important when it comes to information flows is, again, the recognition of what role does information play at all in the first place. And I absolutely agree with you that there are very clear interrelationships on where perceptions are being developed. What's the role, though, of perceptions and in actually enacting the behavior that we observe? That's another question, and clearly it does play some role. But behavioral science themselves say, at the very best, it's 20% of decision making in and of itself, plus then the context that happens on top of that. So I think there's always a danger of when we talk about information, that then therefore we jump to information provision and better information provision. But I'm not sure whether that's necessarily the route that we should be taking. And behavioral sciences have quite an extensive behavioral stock-taking toolkit to understand what are then the drivers of behavior, in addition to people knowing things or people having perceptions of things. And it maybe requires then also fundamentally different knowledge generation in biomedicine, public health, more generally, that we go away from these KAP studies, knowledge edited practice studies, that basically just reproduce our own assumptions. That would be the only thing I think of from the top of my head.
I think that's a very good point. And I also stand corrected. You've mentioned KAP. Perhaps I should be talking about knowledge flows rather than information flows, because I was thinking much more broadly about the way in which people come to understand things, and which these sort of, you know, if you establish regulation in one sector or something, or I mean, it came out of my thinking about Susan's point about the fact that the medical profession is notoriously resistant, particularly in lower and middle income countries where there is a huge amount of medical plurality. They are very resistant to letting others in, as it were. There's a lot of boundary patrolling. So we may say, well, a clear solution to our ethnographic findings that actually people seek care from informal providers is to make sure the informal providers know how to optimize antibiotic use. Well, an ethnographer of India, I know that what will happen is that the doctors' union will go on strike if you try and do that. So I was thinking more broadly about knowledge flows rather than just sort of provision of information, but you absolutely, thank you very much. Over to Mark.
Yeah, as you were speaking, I was speaking the mythologies, the AMR myths, the kind of mythical demanding patient, and the mythical willy-nilly doctor and how those myths sustain a lack of conversation, so that, you know, there's lots of research that's kind of substantiating both of those myths, but where's the research that gets those two archetypes in the room talking about the problem together and coming up with, you know, co-researched kind of language and discourse and ideas. I think we've inherited a kind of schismatic discourse that sustains a lack of conversation. And if we could break that, that would be really part of the response we need to have, I think.
Great. Excellent, Mark. Thank you very much. Over to Susan.
Yeah, thank you, Helen. I think we can't move away from having to address the issue of information on how to use antibiotics, especially if I'm to draw from what's happening in Uganda. It's already happening. Like, with the way things are set up, people are already using these medicines just from doing a simple research and moving around with a drug bag with medicines. People were taking notes and writing the names of medicines and going out and buying them and using them. So whether we like it or not, it would be better maybe to provide, have discussions on the kind of information they should be given, how it should be packaged and all that. But shying away from all this really doesn't do much for what's happening already. It's already happening. So we either get onto, you know, working towards providing information that we feel people need to have, and probably this can be something to be discussed with stakeholders for maybe how to move forward with that, the professionals and all those other key stakeholders in this.
Thank you. Yeah, that's an excellent point. And I think actually, I mean, maybe other social scientists less so, but I think anthropologists in particular have been confronted with quite challenging realities insofar as that we are tasked, as it were, to represent the cultural threads that continue to be enormously important in specific settings. But at the same time, I think as COVID has shown us, the capacity for people to change their behaviors incredibly quickly is also very evident. And I think maybe some approach to trying to shift that language whereby, you know, if you want to talk about context, you're immediately driven to propagating again another myth that Mark has pointed to, that everybody actually kind of continues to do what they do. That's not where we want to sit either. So, and over to Papreen.
I would like to draw give 2 points. One is long-term and other is short-term. The long-term one is knowledge generation, which is, I mean, by now I'm convinced that the rules, laws and regulation that are used for formal sector is not going to work for informal sector. So we need to understand very carefully about the informal sector, which are the 70% or in other contexts, probably 50% of health providers. So, and then if we understand about the informality and informal sector, there would be probably different ways of regulation that sector as well. So we need to generate knowledge on informality. And a quick fix one, probably based on this research for the medical representatives. I think it's a big workforce that Bangladesh has got, but they are not recognized by the formal sector. And if there is a scope of making a collaboration between private and public sector and use this big force of medical representatives in terms of disseminating proper information to the drug sellers, unqualified drug sellers. That would be one way of fixing the problem, probably. Thank you.
Thank you very much indeed for really thoughtful and thought-provoking comments. We have a large number of really great questions in the Q&A. I'm conscious we are almost at the end of the panel, and I feel it would somehow be, perhaps this is foolish, but I feel it would be somehow inequitable to start to just select one or two of these great questions. So may I invite the panelists themselves. You can, if you like, type into the Q&A box and answer questions that are directed to you. And it would be lovely if you could do that. We've got some great issues about questions about the falsification of data, interesting insights on health behavior, and yes, a question from Beth about the distinctions or similarities between what regulation in and what's done in animal husbandry and livestock is not seen as rational in the same way in human healthcare. So precautionary use of antibiotics and so forth. And a couple of questions, particularly about antibiotic awareness, directed to Marco, and it being confusing and not having the desired effect, and the need to make improvements there, which I think is something that probably is a more general issue, which all the panelists would be able to usefully speak to, because we continue to see at global level, really, in terms of policy, all of the publics who you've all talked about in one way or another really being wrapped into this notion of a generic who we need to address through promoting awareness. And I guess to try to summarize some of the points that I've heard, one of the very powerful messages which is coming from all of the work that you're doing in really different settings, and I think valuably including Australia, high income setting, is that not just that context matters in a banal way, but that people are situated in living in multiple roles, operating in various settings, whether they're sort of trying to parent their sick child, or whether they're actually working as a nurse in a healthcare setting in a government hospital by day and then having a private clinic by night, which need to be taken into account, and that perhaps we need to push back somehow against this notion that a generic kind of education around knowing about antibiotics is actually going to solve anything. Perhaps that's not a very upbeat note to end on. I'm sorry I haven't been able to take more questions, but I think this has been a wonderful panel, and I really just want to thank all the speakers very much for their wonderful presentations. Claire, should I hand back to you for a moment, or just announce the upcoming panels?
Thank you. Well, I want to thank you, so you do have to hand back to me so that I can do that. And the whole panel. I'll add my thanks. This was so interesting. I've been typing furious notes. As you may or may not know, we have a plan to try and pull together a report that pulls these 4 panels and the interesting discussions and the emergent kind of questions that people have been asking. We've copied and pasted all of the questions and answers bits as well. So we're hoping that report will be ready in the new year, at which we will then present that at a different type of panel that will be organised towards a different type of audience that you would all be very welcome to join, but also kind of outward facing beyond our social science and AMR community. The next panel in November will be on ecologies, productions and flows. And then, so that's where you might hear some more answers about animals and environment. And then our final panel will be in December, looking at science and technology and infrastructures, and the way that anthropologists and other social scientists have been looking, and geographers and all the different social scientists have been looking at the way that we think with antibiotics in science and how the science is done. So thank you very much again. Huge thanks to each of our panelists. Thank you so much to Helen for managing to create such an interesting and helpful discussion. And thank you to everybody for joining, and we'll see you next time. Round of applause for all our panelists.
Thank you.